Ruptured hepatocellular carcinoma, a surgical and oncologic emergency. Ruptured hepatocellular carcinoma is a critical, life-threatening condition. It accounts for 2 to 15% of all hepatocellular carcinoma (HCC) cases in Western populations and up to 25% in Asian regions, often due to a higher prevalence of large, untreated tumors. The prognosis is generally poor, with historical in-hospital mortality rates between 30 to 50%. However, advances in management have improved patient outcomes. Pathophysiology and risk factors. Mechanisms of rupture. Rapid tumor growth outpaces blood supply, leading to central necrosis and weakening of the tumor capsule. Increased intratumoral pressure, caused by tumor invasion into portal or hepatic veins, resulting in outflow obstruction. Coagulopathy, often associated with cirrhosis, thrombocytopenia, and impaired liver synthetic function. Minor trauma, activities like coughing, vomiting, or physical exertion can precipitate rupture. Vascular erosion, direct erosion of blood vessels within the tumor. Key risk factors. Large tumor size, greater than 5 centimeters, the most significant risk factor. Peripheral or subcapsular location, tumors adjacent to Glisson's capsule. Exophytic growth pattern, tumors protruding from the liver surface. High histological grade, more friable in necrotic tissue. Portal hypertension and coagulopathy, impairing normal blood clotting. Absence of prior treatment, such as TACE or radiotherapy. Clinical presentation and diagnosis. Classic triad, not always present. Sudden, severe right upper quadrant or epigastric pain, present in approximately 90% of cases. Signs of hypovolemic shock, tachycardia, hypotension, pallor, sweating. Abdominal distension and tenderness, guarding and rigidity may be observed. Diagnostic workflow. Step. Procedure. Purpose and findings. 1. Immediate resuscitation. For access, fluid and blood resuscitation, correction of coagulopathy. Hemodynamic stabilization is the priority. 2. Bedside ultrasound, fast. Rapid assessment for free intraperitoneal fluid, hemoperitoneum. Confirms suspicion and guides urgent management. 3. Contrast-enhanced CT, CCT. Once stabilized, multiphase imaging, non-contrast, arterial, portal. Detects active extravasation, sentinel clot, capsule disruption, hemoperitoneum, and characterizes tumor features. 4. Laboratory tests. CBC, coagulation profile, liver function tests, AFP, cross-match. Assess anemia, coagulopathy, baseline liver function, and tumor markers. Management, a phased, multidisciplinary approach. The primary goal is to control bleeding, hemostasis, before addressing the tumor itself. This involves a staged approach with input from various specialties. Phase 1, emergency hemostasis and stabilization. Non-operative management, NOM first line for unstable patients or those with poor liver function. Transarterial embolization, TA/transarterial chemoembolization, TACE the procedure of choice. Catheters deliver embolic agents, gelatin sponge, microspheres, into the hepatic artery feeding the tumor, achieving hemostasis in over 90% of cases. TACE adds chemotherapy but may not be necessary solely for bleeding control. Resuscitative endovascular balloon occlusion of the aorta, REBOA, used in severe, refractory hemorrhage as a temporary measure before definitive treatment. Peritoneal aspiration, paracentesis can relieve tense hemoperitoneum and prevent abdominal compartment syndrome. Phase 2, definitive treatment, post-stabilization. Decisions depend on patient condition, liver function, Child-Pugh score, tumor stage, and response to initial stabilization. Treatment option. Indications/rationale. Considerations. Staged liver resection. Ideal long-term approach if feasible. Involves initial TAE for hemostasis, followed by elective resection 4 to 8 weeks later. Allows patient recovery, better selection, and precise surgery. 5-year survival can reach 30 to 50% in suitable cases. 1-stage emergency resection. Rarely performed today. Suitable if patient is stable, tumor is resectable, liver function is excellent, and TAE is unavailable or unsuccessful. High risk of mortality and morbidity due to physiologic stress of rupture in surgery. Ablative therapies, RFA/MWA. For small ruptured tumors. Usually adjuncts or bridges, not primary emergency treatments. Liver transplantation. Limited cases. Rupture is a relative contraindication due to risk of peritoneal seeding. Requires bridging therapy and careful selection. High dropout rate, controversial. Systemic therapy. For advanced HCC, BCLCC, or as adjuvant therapy if curative options are unavailable. Bevacizumab is antiangiogenic. Therapy should be delayed at least 4 weeks after major bleeding or TAE/TACE. Supportive care. For terminal cases with Child-Pugh cirrhosis, multi-organ failure, or widespread metastasis. Focus on palliation and pain management. Prognosis and staging implications. Rupture automatically upstages the disease to at least BCLC stage C, reflecting the severity of the complication. There is a significant risk of peritoneal dissemination, carcinomatosis, reported in 10 to 25% of cases, which worsens long-term outlook. Historically, survival rates were poor. Modern care involving TAE and staged resection has improved outcomes, with 30-day mortality around 10 to 20%, compared to over 50% with emergency surgery alone. The 5-year survival rate ranges from 15 to 35%, potentially exceeding 50% in carefully selected patients who undergo staged resection. Summary and key takeaways. Suspect RHCC in cirrhotic patients presenting with acute abdomen and shock. Use CT scans to confirm diagnosis, looking for active contrast extravasation. Prioritize resuscitation and involve interventional radiology. TAE/TACE is the primary emergency treatment for bleeding control. Avoid emergency laparotomy if possible, due to high mortality risk. Adopt a staged approach, stabilize with TAE, then plan for elective resection in suitable candidates. Engage a multidisciplinary team including hepatology, interventional radiology, surgery, and oncology for optimal management. While prognosis remains serious, aggressive, protocol-driven treatment can lead to recovery and potential cure in select cases.